Thank you, Mr. Chairman, and many thanks to you and Senator Murray. I think this is the 5th hearing that we have had here. Thank you for your leadership. I'm the co-chair of the Senate Rural Health Caucus, and I am particularly concerned with the growing rise of the opioid epidemic and substance abuse in rural areas. Senator Donnelly and I introduced legislation last year that would help rural areas develop substance abuse prevention, treatment, and recovery facilities. And tomorrow this committee will mark up legislation that I introduced to reauthorize the state offices of rural health. These offices obviously play a very critical role in strengthening the rural health care delivery system by collecting and disseminating data that help inform us make good decisions. Ms. Green, how can we ensure that federal, state, and local efforts to combat the opioid crisis take into the unique situation faced by our rural Americans?
We need to increase our efforts for telehealth and projects like Project Echo out of New Mexico, which is specifically designed to match up practitioners in rural areas with specialists on opioid addiction at various specialty hubs. So that would be one of the best efforts we can make to ensure that there are appropriate resources available to address the opioid problem.
What role can state offices of rural health play in ensuring that the opioid policies are based on reliable data and sound evidence?
In terms of getting reliable data, one of the best things we can do in making sure we have reliable data is to ensure that there's effective coordination at the state level as well as the federal level for the types of data, patient data, that we should be consolidating and making available to different practitioners at different levels, local, state, and federal, to be able to address the opioid crisis. We don't have enough consolidation of patient data, and there's no comprehensive patient prescription history or patient history in any one single source yet.
So we're at the base of the mountain. On the Senate Finance Committee, I'm interested in the potential for the electronic prior authorization. I may be going over plowed ground here, or e-prior authorization within Medicare Part D to strike a proper balance between limiting the unnecessary dispensing of opiates and avoiding overly burdensome requirements. Dr. Mahon, you mentioned in your testimony some successful opiate management initiatives, including the use of prior authorization for certain prescriptions. But I've consistently heard from constituents with concerns about the burdens this practice can place on physicians and patients. How can e-prior authorization be used by Medicare Part D and Medicare Advantage plans to help uphold responsible dispensing of opiates while reducing the physician and patient burden?
Thank you for the question, Senator. Certainly, as we've seen in our data in our program, that if a physician absolutely needs to provide more medication to any given member, they have the ability to request an authorization, a prior authorization of that drug. And where electronic prescribing is going to be critical is prior to the point of prescribing, the physician will already know if this particular drug requires a quantity level limit or a prior authorization. So they're able to go through that process pretty quickly without having to do it after the fact, which is what's really important as we continue to manage this opioid epidemic. But in particular, what we saw in our data that only 4% of all providers that initially wrote a prescription for a 30-day supply that subsequently got reduced to a 7-day supply requested an authorization to give the member more than 7. So clearly,
4%.
Having only 4% of docs requested an authorization where they basically said, thank you, this patient only needs a 7-day supply and it's sufficient.
Well, I thank you for that. The FDA has approved several abuse deterrent formulations, or the ADFs, in recent years, which have shown effectiveness in reducing opiate misuse and abuse. However, many patients still lack the proper access to these drugs due to all sorts of factors. What policy should the federal government consider to increase patient access to ADFs, and what's the relationship between the ADFs and prior authorization?
So from our standpoint, we do caution you to avoid allowing more ADFs into the system. Reasons for that is that these medications are not necessarily abuse proof, right? So they could be abuse deterrent, but they're not abuse proof. And that's really the big difference, that individuals can still continue to overdose on these medications. There's many different techniques online that you can just go and look, how do I boil or cook or do whatever you can do from these medications. So it's really critical that we don't rely just on ADF medications as the single tool. We need to rely on this epidemic to really solve it from multiple angles, educating the physicians, working with the pharmacies, consulting the members to really solve the problem. And ADFs alone are not going to be able to do that.
I appreciate your comprehensive answer. I yield back, Mr. Chairman. Thank you very much.